This is Brian Wood from the University of Washington. In this National HIV Curriculum mini lecture, I will review a recent update to the Opportunistic Infection Guidelines, specifically a major update that gives recommendations for anal cancer screening for people with HIV. The guidelines for the prevention and treatment of opportunistic infections in adult and adolescents with HIV, which was developed by a team from the NIH, CDC, and HIV Medicine Association, can be found at the website shown here at the bottom. The significant update, which added recommendations for screening for anal cancer, was released on July 9th, 2024, and can be found in the section on human papillomavirus, or HPV. As background to why this topic and why these guidelines are important, we know that anal cancer disproportionately affects men and also women with HIV. Men who have sex with men who have HIV are at dramatically increased risk and are one of the highest risk groups for anal cancer. But I do think it's important to note that women with HIV are also at relatively increased risk. Additionally, the incidence of anal cancer is rising, as is the mortality from anal cancer. And this is happening even in the setting of widespread early ART use. I think it's also important to know that anal cancer is preceded by intraepithelial cytologic changes that can be graded, and a higher grade of abnormality portends a higher likelihood of developing into cancer, and clinicians should be familiar with the term HSIL, which stands for high-grade squamous intraepithelial lesions, because anal cancer is preceded by anal HSIL. This is similar to how cervical cancer is preceded by cervical HSIL. In addition to HIV infection itself, a number of risk factors for anal cancer have been identified. These include infection with oncogenic strains of HPV, predominantly HPV 16 and less frequently HPV 18, older age, for individuals with HIV, a history of a low CD4 count, a longer duration of HIV infection, or a longer duration of immune suppression. Other triggers of immune suppression unrelated to HIV, like solid organ transplant and others, can also raise one's risk for anal cancer. For everyone, regardless of HIV serostatus, tobacco smoking increases the risk. Tobacco smoking has been shown to delay or reduce the likelihood of clearance of anal HPV. Genital warts have been found to be a risk factor, not because they develop into anal cancer, but because they are caused by other non-oncogenic strains of HPV and probably indicate a higher likelihood of prior exposure to the oncogenic strains. Presence or history of cervical and vulvar HSIL, or cervical and vulvar cancers, increases the likelihood of anal cancer for individuals who have a cervix and have a vulva. And as I mentioned, a higher grade of cytologic abnormality in the anus also portends a higher likelihood of developing anal cancer. Now, I want to add here there are two main strategies for prevention of anal cancer. One is HPV vaccination, which is a form of primary prevention. It is absolutely important and key, though won't be the focus of the talk today. The other possible intervention is what could be termed secondary prevention, meaning identifying and treating anal HSIL lesions in order to prevent the progression to anal cancer. Now, in the field of cervical cancer prevention, there are data and guidelines to show that identifying and treating or eradicating cervical HSIL prevents the development of cervical cancer. But what we have not had until relatively recently in the field of anal cancer prevention is data showing that identifying and treating anal HSIL effectively prevents anal cancer. So one of the major things that changed within the last couple of years is we finally got that data. We finally got data from this trial called ANCHOR, which did show that identifying and treating anal HSIL was effective at reducing the progression to anal cancer. So I'd like to take a minute to review this trial. This trial also was very influential and informed the guidelines and the new recommendations, so I think it's worth having some familiarity with it. The ANCHOR study was a phase 3 randomized controlled trial conducted at multiple sites in the United States. The investigators enrolled individuals with HIV over age 35, and all of these individuals underwent screening, the screening including anal cytology, sometimes referred to as anal pap smear, and also HRA, which is high-resolution anoscopy. The volunteers for the trial were eligible for randomization only if HSIL was found on that screening evaluation, and they were excluded from the trial if they had any history of anal cancer or if anal cancer was detected at that screening eval. Now, those individuals who enrolled and were eligible for randomization because HSIL was confirmed were then randomized to one of two arms. There was a monitoring arm in which the HSIL was not treated, and individuals in that study group returned for every 6-month digital anal rectal examination, or DARE, HRA, and also biopsy if there were lesions suspicious for HSIL. Those participants in the intervention arm underwent all of those monitoring protocols, but also had an intervention to treat or remove or eradicate any areas of anal HSIL. The treatment could be ablation, excision, or topical therapy. In reality, most of it was ablation by a technique called hyfurcation, but the study was not designed to compare the efficacy of different treatment modalities. It was designed simply to compare whether the intervention being treatment of anal HSIL, was effective at reducing the progression to anal cancer. And these are the key results. The trial was stopped by an external data safety monitoring and review board because, in fact, significantly fewer anal cancer cases developed in the intervention arm as compared to the monitoring arm. At the time the trial was stopped, over 4,400 participants had data to be included in the analysis. The median follow-up time of participants was 25.8 months. And this is the really key part of the results. 9 participants developed invasive anal cancer in the treatment arm as compared to 21 in the monitoring arm. The incidence of anal cancer in the treatment arm was 173 per 100,000 person-years of follow-up, as compared to 402 per 100,000 person-years of follow-up in the monitoring arm. Now, all of this leads to an estimated 57% reduction in anal cancer with treatment of anal HSIL. I will add that treating HSIL overall was well tolerated. There were no major safety concerns. And these incidences of anal cancer in both arms were significantly higher than predicted. The risk of anal cancer was quite high and even more than the investigators had predicted at the outset. This emphasizes to me the importance of integrating these results into anal cancer screening and prevention. And again, we now have guidelines to help do that. So the rationale behind development of anal cancer screening guidelines includes several facets. Number one, the high and rising incidence of anal cancer for people with HIV. Number two, the high prevalence of anal HSIL for people with HIV. Number three, the known high progression rate of anal HSIL to cancer in the absence of treatment. And number four, now from the ANCHOR trial, data showing that treating anal HSIL is effective at reducing the progression to anal cancer. That was the missing piece of the data until the ANCHOR trial results became known. So all of this contributes to a recommendation from the OI guidelines panel that screening for anal HSIL and treating anal HSIL are recommended for people with HIV, and we will talk more about nuances of the guidelines next. The first recommendation in the new guidelines has to do with screening for symptoms that could indicate the presence of anal cancer. So this is likely a practice-changing recommendation because I don't think most clinicians have been doing this to date. The recommendation is to ask all people with HIV at least once per year about anal symptoms. As mentioned in the guidelines, clinicians should ask about symptoms regardless of whether or not the person has ever had a history of anal intercourse. The second part of this, which I think is also probably practice-changing, is if a person does have symptoms and they are a man who has sex with men or a transgender woman who has sex with men and they are below the age of 35, or they don't fit those specific categories but are below age 45 and have symptoms, the next step is clinicians should perform DARE, that's digital anal rectal examination, and standard in-office bedside anoscopy. So this is not high-resolution anoscopy. This can be performed in any exam room in the office. I want to note that the guidelines document does include a couple of helpful links with tips on performing DARE and performing anoscopy. So if these clinic-based bedside office procedures are new to you, I'd encourage you to take a look at those links. I just want to emphasize that these can be done in the office and these are within the purview of primary care. And next, I want to turn to a key algorithm in the new guidelines. This is the recommended screening approach for men who have sex with men and transgender women who have sex with men who are over 35 years of age, and for other individuals with HIV who are over 45 years of age. And this algorithm includes recommendations whether an individual has symptoms or is asymptomatic. So this integrates screening for individuals without any anal symptoms. And the algorithm depends on a few factors, including patient age, patient gender, gender of sex partners, and importantly, whether HRA, again, that's high resolution anoscopy, is available or not. So those are key considerations to start with. This is definitely a change to practice and will evolve in the future as hopefully more providers become formally trained in high resolution anoscopy. But I'd like to take a moment to walk through this algorithm. Starting at the top, you can see, again, this pertains to men who have sex with men and trans women over the age of 35, other individuals in HIV primary care clinical practice who are over 45 years of age. And then the next decision point is whether HRA is available or not, meaning do you have access to refer to a provider trained in high resolution anoscopy? If the answer is no, then the recommended next step is assess for anal symptoms and perform DARE, or digital anal rectal exam. If there are no symptoms and no abnormalities on DARE, the guidelines suggest repeating that process in 1 year. If there are symptoms or abnormalities on DARE, the recommendation is to perform standard anoscopy. If there are any abnormalities on the standard anoscopy, then clinicians would need to seek referral to a specialist who can help further evaluate those abnormalities. That might be a colorectal surgeon or other specialist. If we go back up to the top of the algorithm and go to the right side, you can see if HRA is available, and this is the preferred strategy, then the recommendation is to assess for anal symptoms and collect anal specimens. The specimens would include an anal swab for cytology, sometimes referred to as anal pap, and ideally co-testing for high-risk strains of HPV virus. Then the guidelines suggest performing DARE. And I want to note this is important that specimens should be collected prior to performing DARE because the lubricant used with DARE might affect the cells collected for the specimen. So specimens should be collected before the DARE exam. And then per this guideline algorithm, if there are no symptoms and no abnormalities on DARE, then one should look to the results from the anal cytology and the HPV testing to define the next steps, and we'll look at that on the next slide. However, if there are symptoms or any abnormalities on DARE, then one should refer to a specially trained HRA provider. Now, this figure from the guidelines advises on the next best steps based on results of the specimens collected. An important point from this figure is anal cytology and HPV testing should only be performed if you have access to a referral provider trained in HRA. If you don't yet have a referral provider trained and comfortable with HRA, then the guidelines do not recommend performing the anal pap, which is the cytology testing. Now, looking at the left part of this figure, if high-risk HPV co-testing was not performed and cytology or anal pap was normal, it should be repeated in 1 year, and then if normal for 3 consecutive years, the frequency can be reduced and it can be repeated after 3 years. If, on the other hand, the cytology was abnormal, meaning any abnormality, ascus or greater, then the recommendation is to refer for HRA. Turning to the right side of the figure, if HPV co-testing was performed along with cytology, you can see the recommendations first based on the cytology result, normal, ascus, and then LSIL or greater. And you can see that if the cytology result was LSIL or greater, then the next step should be HRA referral. If the cytology result was normal or ascus, then clinicians should use the high-risk HPV result to determine whether referral is indicated or whether testing should be repeated, and then also the interval for repeating it. Now, I want to emphasize that this is very momentous to have guidelines for anal cancer screening for people with HIV. We were awaiting these for a very long time. That said, I think there will be significant hurdles to implementing these guidelines. First, I think patient education about the importance of screening and the reasons for screening is going to be key. A lot of patients have never thought about anal cancer or screening or prevention before, and I think patient education campaigns will go a long way towards promoting the success of screening protocols. Second, and probably the biggest hurdle, is there are a limited number of HRA trained providers in the country, and access to HRA is currently limited in many regions. Performing HRA takes formal training, it takes practice. It is not a see one, do one, teach one type of procedure. And even centers that have HRA trained providers currently are going to have challenges because they will be overwhelmed with referrals once these guidelines are implemented. So we will have more discussions about these challenges in the future on the National HIV Curriculum site. In the meantime, I think clinics will need to review the guidelines, discuss how best to implement them given local resources and current capacity of their HRA-trained referral specialists if available. And I suspect many may need to prioritize patients who have multiple risk factors or who have the highest concern or highest suspicion for HSIL. But hopefully with time, more providers will obtain HRA training and access and capacity will improve. Finally, to summarize the key points, HPV infection, anal cancer precursor lesions, and anal cancer are more prevalent in persons with HIV. Incidence is rising, as is mortality from anal cancer. We now have data showing that identification and treatment of anal cancer precursor lesions prevents development of cancer. And these new recommendations give guidance on evaluating anal cancer symptoms and screening for anal cancer for asymptomatic people with HIV. Screening protocols are going to depend on HRA availability, and hopefully that availability improves over time. And finally, a reminder to not forget HPV vaccination as a key part of anal cancer prevention.
The production of this National HIV Curriculum Mini-Lecture was supported by grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA Program and do not necessarily represent the official views of HRSA or HHS.